Welcome, everybody, today's local partners session on lessons learned and looking ahead, the future of HIV testing services. My name is Vincent Wong. I'm really happy to be here with you all today, and I am actually substitute moderating the person who coordinated this session, Liz Manfredini, and unfortunately wasn't able to make the session to moderate it, but I wanted to give her credit because she's done a lot to help coordinate and shape today's session. So today we'll be hearing from two excellent colleagues, no pun intended, Dr. Carrie Cox from Baylor College of Medicine in Malawi, and Dr. Marie-Lina Excellent from Institut pour la Santé, la Population et le Développement in Haiti. Pardon my French. I've got a few introductory slides. My name is Vincent Wong. I'm with USAID's Office of HIV/AIDS. I am a branch chief for behavioral and structural interventions, but have spent about a decade working on HIV testing, service policy, programming, and research. So I'm happy to be here. We can move to the next slide, please. Okay, so here's our overview. Welcome. I'll provide just a couple of preliminary remarks, and then we'll move right into our panelist introductions, and then we'll have quite a bit of time for questions and answers. And if folks want to enter questions into the chat, feel free to do so in the interim. Okay, next slide. Next slide, please. Perfect, thank you. So just a couple of pieces of information. The first on the right here is the UNAIDS latest estimates on global estimates on the first 90, the knowledge of status among persons living with HIV/AIDS. We're at 84%. There's a lot of regional differences. There's a lot of country differences, but it shows us the gap to reaching the first 90 of about 2.3 million people, and then the first 95% of PL/HIV knowing their status of 1.9 million people to be diagnosed as of 2020, actually reported in 2021. So that's where we stand globally. On the left here, I've just listed down some of the key changes that we're looking towards in COP22 and the COP22 guidance. These are all draft proposals. They've been kind of put into the draft COP guidance, and they may change, right? But I think a lot of them are quite sound and probably will resonate with many of you and inform a little bit or provide a little bit of context for the discussions today. But one of the main things is going to be the PL/HIV gap analysis and thinking about who's left to diagnose in a given country and how are we reaching them, or even in a given region. That's going to be critical in terms of testing planning in the coming years, and we'll speak to some of the topics we'll talk about today. There's issues on retesting. We've highlighted the new WHO guidance, re-released in 2020, but established in 2019 on HIV testing. There's a lot on offering safe and ethical index testing of 100% of eligible individuals. That's not necessarily new, but it is re-emphasized. And then there's quite a bit on screening tools to try to ensure diagnosis and optimize our programming. There's a bit on PrEP, and then also HIV testing in prevention services, which is something of a new section, just thinking around how are we integrating prevention for ensuring folks are HIV negative in our prevention services. So next slide, please. So just a couple of slides on gaps. This is one on the pediatric gap, and we know that those under 15 years of age are lagging behind in all of the 95 indicators. Here on the left, the first 90, which relates to some of our sessions today, at 65%, and quite substantial need in terms of diagnosis in those age bands for children infected. And then the next slide, please. And these data are all mostly from UNAIDS. And then the gender differentials, we often hear about undiagnosed men. And here is the current picture of that, noting that about 1/3 of new infections are in males over 15 years of age. And we see that in the green bars on the left-hand side, and then the lagging indicator again on the first 90 of adult males versus adult women. So just to keep those gaps in mind, we had some COP shifts, and we have the population gaps, and these are populations that we need to program our testing to. So we will hear from our panelists on two effective approaches to accomplishing that today. Our first, we're going to hear from Dr. Carrie Cox from Malawi. Dr. Cox is a board-certified internal medicine and pediatric trained physician with 10 years of experience in clinical medicine, program and guidelines development, and operational research. She's led development and scale-up of innovative adolescent health programming in Malawi, and created novel programming, training, and mentorship with adolescent support services, working collaboratively with the Ministry of Health there. So without further delay, I'd like to move to the next slide and turn the mic over to Dr. Cox. Take it away, please.
Great, thank you so much. So I am presenting today on behalf of our team from Baylor Malawi Tingate program, and the work we did on optimizing case finding through a surge activity in Malawi. Next slide. So I have nothing to disclose. Right, so as we're all aware, HIV testing is a critical step in HIV prevention care and treatment services. Globally, about 80% of people living with HIV know their status, and in Malawi, about 90% do. Index case testing, or ICT, offering HIV testing to sexual contacts and children of people living with HIV, is a WHO recommended strategy to identify and link people living with HIV and at-risk HIV negative people to treatment and prevention services respectively. So in Malawi, during the first COVID wave, there were significant movement restrictions put in place as part of COVID mitigation strategies. And as such, opportunities to offer index case testing to contacts of people living with HIV were missed. So from October to December of 2020, Baylor Malawi rapidly scaled up ICT contact tracing, and this is what we call our surge, to mitigate these missed ICT opportunities from reduced activities due to these COVID-19 restrictions. And what we're doing today is describing the impact of these surge activities on our HIV case finding and yield. Next slide, great. So the surge was conducted for 3 months, from October to December 2020, at 30 medium to high volume ART clinics within the 7 districts that are highlighted here in green that are supported by Baylor Malawi. All of these sites have Baylor Malawi Tingate Outreach Program site-based staff that include community health workers, counselors, clinical mentors, and they're based there at the site, or they travel there on ART days and as needed to support. So next slide. So during this surge, all untested ICT contacts that had been elicited in the preceding 3 months who were not yet offered HIV testing were assigned to a community health worker. And this community health worker traced the contact and offered them HIV testing. The tracing included phone and in-person tracing on foot, by bicycle, and with motorcycles. And as well, we had additional vehicle hire to support tracing of clients who lived far from the facilities. We had expanded testing hours that were supported, including early morning, evenings, and weekends. And there was expanded use of self-testing. And additionally, we provided intensified virtual supervision of both tracing planning and outcomes of the tracing. All the HTS was voluntary, and newly identified people living with HIV were immediately linked to care. So the weekly data on the total contacts tested and the new positives identified, they were collected from ICT registers over 22 consecutive weeks. So 11 weeks pre-intervention, 11 weeks post-intervention. And then a single group interrupted time series analysis is what we're going to describe here that was used to analyze the effects of the surge on both the number of contacts tested and the number identified as HIV positive. So this is the results, and it's a bit of a busy slide. You'll see on the left is the pre-intervention, and the right column is the post-intervention surge period. And so you'll see during the surge, the right column shows there was an absolute number of tests done and people living with HIV that increased. So there were 495 people living with HIV that were newly identified out of about 3,800 tests that were conducted. And this compares to the column on the left during that equal 11-week period, there were 190 people living with HIV newly identified out of about 1,000 people tested before the surge period. And additionally, if you look at the number of tests done per week, though that increased by 37 tests per week throughout the surge period, which was a statistically significant change. With more tests on the bottom, though, you'll see the yield did not change significantly. It trended down from about 20 to 15% during the surge. So in other words, in summary, as you would expect, doing more tests results in finding more people living with HIV, but doing more ICT doesn't change the yield. And this is particularly relevant because the surge was a lot of effort of both human resource and financial resources, with extra hours dedicated to ICT during the regular workday, as well as the early morning, evening, and weekends, as well as the additional travel with hired vehicles. And obviously, time spent doing ICT is time spent not delivering other services. So in conclusion, the initial increase in case finding during the surge did not persist even with a sustained increased testing volumes. So more tests were needed to identify each additional newly diagnosed contact. And given resource limitations, the implementation of these higher effort strategies like ICT must be balanced with lower yield, lower effort strategies to preserve adequate resources for other critical prevention and treatment services, including adherence and retention support, counseling, and viral load monitoring. Thank you.
Great. Thank you, Dr. Cox. So we're doing quite well on time. We're about 13 minutes past the hour. So I thought we could actually take a few questions before we move on to Dr. Excellent. So I wanted to see if there are if folks had any questions they'd like to ask immediately to Dr. Cox. And just to note that there's a raise hand function throughout the session if folks want to use that on the bottom right. But I'll jump in with one question or one comment and question that I had as you went through your data. One was that I think right now there's a lot of thought around the balance between yield and case finding and where the perfect place is to be. For a long time, we've been really prioritizing the positivity rate and saying, well, higher positivity is more efficient, is more effective, and we should be driving towards that as the indicator of concern. But more and more we're realizing that the higher positivity we have, the more cases we're missing. And I think some of your data shows that actually if we compromise a little bit on the positivity, we can actually gain a lot on the diagnostic side and reach more people with testing who are infected. So one question would just be to be your thoughts on that balance. Right now, we are working within the COP guidance to retweak that a little bit and sort of set for instance, the index testing positivity rate that we'd like to see at or above 10%, which your program would have fallen into. And we've done that just looking at historic data across PEPFAR. But it would be interesting to hear your thoughts on that. And then the second thing the second kind of question that came to mind was the sustainability of the surge. As you said, it was human resource intensive. You were trying to leverage self-testing. what are your thoughts on the sustainability of delivering that level of service to reach partners of newly diagnosed? Thanks, over.
Sure, great, thank you. No, I certainly agree on the yield situation that doing more testing, the yield does drop, so you won't reach those very high anticipated or target of yield for index case testing with more tests done. But obviously, the absolute number of people found does increase with more tests done. I think that that number also relates to other testing as well. Other testing, with more tests done, you also find more people. And I think that balance, and I think a yield of more than 10% would be much more achievable, and I think allow that balance, as you mentioned, the sustainability, because this was and maybe I didn't highlight enough, but a huge effort of time and coordination, and just that the community health workers who do our testing at the facility, so much of their time was dedicated to this, that other services were they were done, but less, right? There's only so much time in the day. And so I think that that balance of identifying what service, how much ICT with this tracing is reasonable to balance within the overall prevention and treatment services that we're aiming to deliver, so that we can identify new positives, but also retain those who are identified into care, and obviously also identify at-risk negative people. And as in Malawi, we actually have more access to prevention services with PrEP that's rolling out, like linking at-risk people to these services is also valuable. So identifying both the positive and at-risk negative that you're reaching as valuable.
Yeah, excellent points. Thank you for elaborating and noting. Yes, the at-risk negatives are really also a kind of a target population in terms of serodiscordancy. A couple of questions from the chat. Anna was asking on the results, was there a difference in the outcomes of yield among children and adolescents versus adults in the surge activity? And then I'll tack on one more. Olympia asks, do you know the costs for positives identified, or do you have some costing data for the surge undertaken? Over.
Yeah, we don't. We would love to. We don't have any costing data right now, but if we would be happy to share that if we get it, but we don't have that right now. And there is a difference in the positivity for adults, sexual contacts, and children. I don't have the absolute numbers, but they're as expected. The pediatric yield is lower, but it's within the range of, I think it's within the range of about 5 to 7%, which is what we would expect with pediatrics, and the adult yield is higher. But I can share those absolute numbers with
Great, thank you.
Yeah.
Let me see. Bongili is asking, what is your testing rate of the contacts given? So it would be interesting. So just in terms of the downstream cascade, about how many contacts were each client given, and how many of those accepted, if you know those, and then someone was asking about the integration, and Xavier was asking about the integration and response of HIV self-testing, which I would also be interested in.
Yes, so there was a lag, there was such a lag here in that these contacts were identified sort of about 3 months prior during the surge. So on average, we had about 2 contacts per index, but we didn't find all of them because of that delay in the tracing because of the surge. So it was that 3 months prior. So we didn't find all of them. Those that we found had high rates of accepting testing. I saw and obviously all of this was offering testing, it wasn't requiring testing. So HTS is always consented as any HIV testing service. And then with, I apologize, the second question, I don't remember.
Oh, sure. Self-testing, how that
Self-testing.
worked and was integrated.
Yeah. So we incorporated self-testing that some of the community health workers, so most of them traveled by these bicycles out, and many of them are self-testing trained, but might not be HIV testing trained. So they were offered to index cases throughout the COVID mitigation period to offer to their contacts. And then if the community health worker that was tracing them wasn't a counselor, wasn't able to do a self-test, wasn't able to do a blood-based test at the home, they weren't a trained counselor, they also had self-test kits they could offer to people if they wanted to use them. So they were incorporated both for the index at identification and then when doing tracing. So.
Great. And was there a sense, or was there anything quantified that showed that was like a successful strategy?
Yeah, it's so, we know how many we distribute, but the number used, unless they were used directly with the CHW there, like if the client or contact asked for the community health worker to assist them, we don't have the number of people that come back and report that they actually used the test. We think it's much higher than what's reported because what's reported is so low. But I think that is something we see like throughout Malawi for sure. And I think it's sort of a challenge of self-testing. We know how many we give out, but who uses, that's the beauty of self-testing, is it's your private use.
Yeah, absolutely. And it's noted, I think, with the self-testing as a tool and a strategy, we don't need to know the outcome of every single self-test, but if we kind of have a sense that, or have some data that shows that it's kind of effective downstream with a population, then that's enough. Okay, I'll slip in one more question, and I think it relates to some of the others. But given there's been a lot of concern over the past 18 months around safe and ethical index testing, negative outcomes of index testing, and you've kind of conducted a surge, right? We've kind of amplified the amount of index testing that's happening within your program in a short term. First of all, were there any negative outcomes that you were aware of as a result of that surge in index testing? And then secondarily, have there been any processes or anything put in place to try to ensure that we're meeting minimum standards and making sure sort of bad things don't happen as we seek to reach partners of newly diagnosed? Over.
Yeah, sure. No, we're very aware of this. So all of these clients that were offered active partner tracing are screened for intimate partner violence. So if they have any known, obviously, intimate partner violence, they're not offered. They would not have been traced. And so that screening is done at the time of index identifying and counseling the index client. All of our staff have been trained in the GBV Lives counseling and would provide that initial site-based first level counseling for any index client that, or any client, any person that identifies as being a survivor of gender-based violence. We did not have any known adverse events from tracing and doing index testing during this surge. So yeah, we're happy that is the case. But certainly anyone that was known to be at risk wasn't offered the service. They were, yeah.
Great, thanks so much, Dr. Cox. Yeah. Okay, so with that, we will we'll move on to our next presenter, and I think we'll still have time at the end for further questions. If folks have them, you can continue to put questions into the chat, and we'll try to get to as many as we're able to. And so right now we'd like to introduce Dr. Marie-Lena Excellent, who is a physician from Haiti who earned her master's in public health in 2016 from UNC Gilling School of Public Health in Chapel Hill, thanks to a dual scholarship from Fulbright and UNC. So thank you to them. She's led the HIV/AIDS department at teaching hospitals in Haiti and is a technical advisor for HIV testing services and continuous quality improvement at both the EQUIP project in Haiti and the Bridge ISPD projects. She's provided extensive training and mentoring to frontline providers and health facilities and supported the Haitian National AIDS Control Program. So we're really happy to have Dr. Excellent here with us today, and she's going to be talking to you about reaching men. So I'll turn it over to Dr. Excellent, and please take it away. Thank you.
Thank you very much, Vincent. So we will discuss about interventions that we conducted to help improve access to HIV testing services for at-risk, hard-to-reach male through regional male-friendly clinic outreach, as well as the implications for the National AIDS Control Program of Haiti. And please, next slide. Next slide, please. Thank you. But before we dive into our subject today, I would like to provide some context about the Project Bridge and overview. So we have Institut pour la Santé, la Population et le Développement, ISPD, which is a local young nonprofit organization based in Haiti that's committed to promote HIV/AIDS best practices. ISPD was tasked to implement the Project Bridge, which focuses on providing a differentiated HIV service delivery and for priority populations, including migrants, hard-to-reach male, and it's funded by PEPFAR USAID. The main area of focus for implementation of that project includes providing a comprehensive and patient-centered package of HIV prevention, care, and treatment services, differentiated model of care so that it's patient-centered in an innovative way and collaborative approach, primarily with the Ministry of Health and particularly the National AIDS Control Program, NLS, of Haiti and its partner to fight gender-based violence, stigma, discrimination, and other issues that particularly affect the target population and limit access to care. Next slide, please. Now, just a few words about the context and background of our work. In Haiti, more than half of male individuals have never been tested for HIV. And in response to that disparity in access to HIV testing services, ISPD implemented male-friendly clinics. Those male-friendly clinics focuses on outreach interventions to help not only reach the hard-to-reach at-risk male, but also to improve access and also hopefully reach the first 95 of UNAIDS goals. Yes, please. Now, a few words about what we did, our intervention. So first of all, we provided trainings to providers and community health workers. And those training sessions, as you can see in the pictures, moving from left to right, it's about patient-centered services and HIS, so HIV testing services, national guidelines and the tools. And also in the middle, the picture in the middle, it's in collaboration with the National Laboratory of Public Health, where we make sure that the providers are also trained to perform accurately the HIV rapid test. And the picture on the right is really just to illustrate how we customize our outreach prevention. We are very male-driven, so we make sure that we have activities and also a package of services targeted male that aim to attract males. And we were also able to identify hotspot and hard to reach male who are at high risk for HIV. And we also conducted sensitization sessions targeting males, of course, but particularly at public transportation, like public transportation drivers, homeless male, and mobile, including those particularly working or living at the borders. Next, please. This is one illustration of a package of services that we offered at the Malpass border in collaboration with, again, the Ministry of Health. And we identified that particular has hotspot for HIV. There's a lot of transactional sex going on there as well. So this was an activity that we conducted on the AIDS World Day 2020, and it was successful. Next, please. This is to make sure that we provided standardized care. We make sure that we developed a questionnaire to help assess the risk for not only HIV, but also other sexually transmitted disease. And we offered that to male and they can decline. So it's always voluntary. And then those who are found to be at risk based on their responses to the questionnaire were offered HIV testing services. And the clients could decline at any time of the process. So once the patient or the client had a positive HIV test, then we make sure that we had available community health workers or health agent liaison to make sure that those clients or those male were accompanied to a male-friendly clinic of their choice to receive a comprehensive package of services in a stigma-free environment. Next, please. So once they would reach those friendly male clinic, as you can see, they receive timely access to preventive care and healthcare services based on their needs. And those that package generally include urologic care, screening for sexually transmitted infections, PrEP, HIV care treatment, and general outpatient care as well. We would like to specify that even if we are, we have male-friendly clinic, but we are open as well for their family or partners as well. And we conducted weekly review of the HIV testing services data to help monitor progress and address challenges proactively. And the picture on the right is just one of the Minister of Health apps that help follow ICT, but we will not talk about it. Next, please. These are the results in overall. So our baseline data showed that only 376 male were actually tested for HIV, and we had a yield of 4%. But once we implemented the male-friendly clinic, and which is heavy on outreach, so we go where we can find them and then we screen those male. So we were able to improve not only the number of male tested for HIV, but also find more positive. So we were able to improve our yield as well. And in the last quarter, we actually were able to notice, comparing to the baseline data, a significant increase in access to not only HTS services, but also just services in general for male. Therefore, we believe that targeted outreach combined to male-friendly clinic, access to male-friendly clinic, definitely lead to increase the proportion of male accessing HTS and a significant increase in the positivity rate. Next, please. So as you may presume or anticipated, there are always challenges whenever we are implementing interventions, and this project, it's no exception. First of all, a male culture or belief about attending health facility, it's one of the challenges because in Haiti, most of the health facilities are attended by female. So male don't really attend them. They that they don't have time. So, and those health facilities are most of the time very crowded. So anyway, inpatient, patient being inpatient, as we joke about it as physician. So what did we do? We implement regional mid-friendly clinics where a male will feel not only receiving timely, good quality of services, but also having having a package of services that is centered around male. You know, welcoming environment with timely delivery. So we adjust to their work employment or their time, their availability. We are very patient-centered. Second challenge is regarding the violent protests that led to several cancellations of our outreach activities in targeted communities, particularly at the borders. Therefore, we had to schedule outreach activities also in the weekends. Third main challenges, it's the limitation of available HIV self-test kits that are allowed to quote per site for outreach interventions. So how did we mitigate that? We use the HIV risk assessment questionnaire to screen and objectively identify people who actually needed an HIV self-test, as well as the standardized HIV rapid test. Last but not least, disclosure of HIV status to sexual partners remain voluntary in Haiti. So there's no legal policy that would, I don't want to say that would force, but that would require someone tested positive for HIV to disclose their status. Therefore, we adopted the HIV index contact testing national guidelines and national app to help improve access to HIV testing services, where people exposed to HIV had the opportunity to still access HTS without any disclosure. So the Ministry of Health would collaborate with the Ministry of Health, particularly the National AIDS Control Program, make sure that the guidelines were in compliance with the reality in the field. Next, please. In conclusion, we believe that based on the findings that male-driven outreach interventions have increased access to health services, particularly for males. And we think that the expansion of that strategy collectively may help achieve the 395 of the UNAIDS goal that the Ministry of Health is committed to. Next, please. And we would like to acknowledge all those partners, the Ministry of Health, PEPFAR, USAID, and last but not least, definitely the community that we serve for trusting us with their lives. Next, please. And this is a picture of our ISPD bridge team. And we are very thankful for your time and attention. And we look forward to answering questions. Thank you.
Oh, thank you, Doctor. Excellent, fantastic, rich presentation. There's so much in there to discuss. And thanks for the fantastic photograph at the end. That was really nice to see. So I'm going to move to the chat to ask a few questions that that the audience is putting forward. The first two are kind of connected. So one is, you mentioned hotspots and outreach to specific hotspots. So it'd be interesting to hear from you how that was defined, how that was viewed, how you sort of strategized around around hotspots and populations. And then Xavier asks, I understand that males were targeted. Can you share a specific strategy that was found to be effective? How exactly did you attract men? And I think this extends also into the sensitization that you discussed. So those two areas, if you could elaborate. Thanks.
Definitely. Thank you for the questions. So the first question is about hotspot. So normally what we would do, we would go to the HTS registered register that it's a national tool that we have to use. So we would see once we have someone with an HIV positive test results, we will see, okay, where does that person live? So identify the address and see if we have more than one person tested positive in that particular community. And most of the time you will find 2 to 5 person very living close to each other. Therefore, this is a hotspot, and we would develop and plan an outreach intervention there, where we not only do awareness, we also sometimes reach out to those people who are positive, tested positive, and enroll on ART, and they serve as community champion without disclosing their status, their HIV status. They just go there and promote the male-friendly clinic. So, and this is it's our part to do awareness, conduct the screening, talk about the package of services that we offered. And then that has helped a lot to screen and identify more male at risk for HIV. So this is one part with about the hotspot. The second question was, I forgot.
That's okay. You spoke to it a bit, sensitization. What were your efforts at sensitization to increase acceptability of the services?
Yes, good question. Yeah, now I remember. So what do we do to attract male? I think that was the question. So first of all, when male go to general health facility, they're already crowded with female, and this is a reality in Haiti. So most of the time when you have public transportation driver, they may have very short time break during the day. But unfortunately, the waiting time is so long that unless they are really, really badly sick, they will go to health facility. But if they feel okay, they want. And what we do to attract them is that with those male-friendly clinic, we make sure that we have package of services that are targeted to them, because sometimes they would go to a health facility and having urologic issues or having erectile dysfunction issues, but there's no specialist there to attend them or to meet their needs. So with those male-friendly clinic, we really address in a non-stigma way those needs for male. And also in the waiting room, we make sure that we have some cardboard games just to keep them busy as they wait for their test results and everything.
Excellent. So Olympia asks, and this relates a little bit. So you're able to kind of attract males to the clinic to engage, to wait in line to get their services. There's integration of services, which is excellent and increases acceptability and actually meets the needs of the population. Olympia asks a follow-up to that and asks, did you hire male providers for every clinic? Did they work extended hours? And then how sustainable is this intervention? All good questions. Over.
Yes, these are all great questions, and we have talked about all of those. So first of all, we're debating, okay, should we have female providers? But we end up having a mix of both. So it doesn't really matter. What we make sure that our staff entirely is trained about male-friendly clinics. Services. So, but again, so far we try to have the physician as a male, just because we think that, again, it's about culture. So we think that they will feel more comfortable interacting with a male provider at a male-friendly clinic than a female. But sometimes if the clinic is really overflowed, even myself or other colleagues, we step in, and that's okay. But we try to have primarily male for physician, but we have nurses and they are female. So it doesn't really matter. And what we do at those male-friendly clinics is that we have every day From a quality improvement perspective, we make sure that we receive feedback, we ask for their feedback anonymously. How was your experience today? And we use emoji scale so that they just can say, excellent, it was satisfactory, or you suck, guys. So we act on them. So we learn as we go. Thank you.
Excellent. And also excellent to hear about the CQI, which is always important in achieving good outcomes with all services. There were two related questions here. I've got to scroll through. So one was, we were finding some challenges with linking same day of our men in the male corners. They need additional counseling. And also most men fall out of care within 3 months post-diagnosis for a number of reasons. Can I ask about linkage rates, especially same day, and what was the retention rate at 3 months in your program? And that was from Bongela from IntraHealth. And then there was a related question here about how you ensure retention and care and treatment for mobile populations that you serve. For programs serving general populations, what strategies would you recommend targeting men? So linkage, retention, engagement, what can you say to that?
Okay, these are all great and excellent questions. So first, the linkage. So what we do at ISPD through the Bridge project is that we have noticed it's exactly that referral, there's a lot of loss to follow up when you do referrals. But when you make sure that you have someone on site to make the journey with the person, so accompany the person to, the male client, to a health facility, to the male-friendly clinics of their choice, because we have a couple. So that makes a difference. And when that person, and it's not, I'm quoting here, so those male participant or clients, they said that they feel supported, they feel that I'm not alone, I'm not on my own to find a place. And once they reach their destination, then they receive a really welcoming, we thank them for coming. So that makes a difference. Referencing them, doing referral versus accompaniment. So you go together with the person. That makes a difference, and that also has improved the retention. Other strategy that we have used to improve the retention, it's also our flexibility with schedule. For example, if a male said, oh, I can attend clinic at 4 p.m., it's okay. But at other clinic, it's not okay. You have to be there at 8 or 9 to receive care. So we try to accommodate and trying to address the barriers that prevent male or that stop male from attending other health facility, because we said that we are male friendly. We need to take into consideration their reality as well. So they don't really have time. And also we have some patient who cannot attend clinic at all during the weekdays. It has to be a weekend. And that's why even when we are hiring the staff, they know that there's weekend as well. So it's based on the patient availability so that we make sure that we customize care to their needs. Regarding data regarding retention at 3 months, I don't have that on top of my head. But I know that our project does have those data, and we'll be more than happy to share.
Great, thanks, Dr. Excellent. And I think it speaks to the need to be client-centric as is possible within the program to deliver the services that people need, and not, adjusting the hours, bundling the services that drive acceptability and need are really important. Okay, we've got time. If for folks that didn't see Latham's comment, we have to end 5 minutes early, so we'll do a few more questions and then we'll conclude. there was a question from Vera on, with secondary distribution of HIV self-testing, did this increase access to the clinics? What follow-up was made to secondary distribution? So maybe you can just speak to the self-testing component of your programming and how that might have helped or may not have helped from your perspective. Over.
I believe that it helped. But in Haiti, and it's again based on our national guidelines. So the Ministry of Health has opted for the assisted HIV self-test, meaning that I cannot hand someone an HIV self-test and then just walk away. I can't. There has to be some support and some assistance. It's required. So what it was very helpful, especially at the borders. Because we try to limit the waiting time because it's a very active area. So people are not used to stay there and waiting. So we have to be really, really dynamic in the delivery of services. So the HIV self-test, again, before we offered it, we screened so that we don't test to someone who is not at risk at all. Which is helpful. So we screen to identify or confirm the eligibility of those clients. And then once they are eligible, then we perform the test, and it's a very rapid test. So up to 20 minutes maximum, you get your results. And the result is either it's reactive or non-reactive. And based on the national algorithm, once you have a reactive HIV self-test, that person definitely need to confirm to have a blood HIV rapid test. So what we do to preserve the confidentiality so that people don't, oh, that person is taking more than 20 or 30 minutes. So to avoid that, so we do the accompanying, we have people accompanied those clients mailed with reactive HIV self-test to the closest male-friendly clinics so that they can receive in confidentiality, privacy, the HIV rapid test. And of course, at any time, the client can decline or postpone or defer, and which is okay.
Great. Thank you. I've also got so many questions. I guess one question that I'd like to understand is about your risk screening. So there's been different views on risk screening. One that they can be really useful at getting people who might not test to test because it elaborates that you may, for different reasons, benefit from testing, and then others that, oh, we might be, through asking a lot of questions, screening people out who need a test and trying to find this balance. Do you have any sort of data or insights into how well your risk screening test is working? I noted you increased positivity and you also increased volume. I worry when positivity goes up and volume goes down, but you increased both. So it'd be interesting just to hear your thoughts on risk screening.
Definitely. So the development of the HIV risk assessment was driven by the data. So what happened is that we were over testing people, and also there was I would say a practice, not good practice, of some people who would be tested for HIV every quarter on a quarterly basis without any risk for HIV whatsoever, just because they think that, oh, it's a regular checkup, and it's not. So we developed, in response to that, we developed the HIV risk assessment that aims to not only identify risk for HIV, but also STI. And we were able to identify some people were not at risk for HIV per se, but they had somehow occurring STI. So if you had STI, then you're at risk for HIV. But others, people also were, clean for HIV and STI. And I mean by clean, not at risk, no symptoms, but also identified with TB symptoms. So which that questionnaire helped also assess. So we were able to identify people who were ultimately diagnosed with TB, that there was no way for us to know even them to know because they don't go to clinic. So that to us, it's not the risk assessment tools is not just about HIV testing. It helps us really provide access to care in general.
Great. Thank you, Dr. Excellent. So let me see. I wanted to see if we're getting to all the questions. There was a question about integration of either GBV screening or screening for or integrating services looking at gender-based violence within the male population, and then any experiences on integration of nutrition sessions into your program. Over.
Thank you. So I can speak about the first one, the GBD, because actually we developed also a questionnaire for about GBD, but it was in response to index contact testing. Even if disclosure, we cannot disclose per the national guidelines, we cannot, but we also, there were some index patients, particularly the females. They would have some sexual partners and not feeling comfortable revealing or disclosing their address or phone number so that we could reach out to them anonymously. So we tried to brainstorm and asking ourselves, okay, what are some barriers? And we had focus group with group of support with some of the index patients, and we asked, okay, why would you decline the offer of ICT? And they said, well, I fear that my partner may have suspicion and then become violent, or he has a temper, or I'm not daring trying. So we figured that we were gathering that information downstream instead of upstream. So the questionnaire we adapted based on evidence, former question, particularly those developed by the CDC. So we adapted to our reality, and then we include that in the package of HTS as a starting point. So once a patient or a client is tested positive for HIV, then we offer that. And if the patient is not ready, then we wait until next appointment. So that's for the GBD. Regarding nutrition, we talk about healthy diet, but because we do not really have a large pediatric population, so adult male tends to not really be, into nutrition that much. So, but if they have questions, our staff is trained to answer that. But most of the time, the focus on nutrition is primarily for pediatric population. But we encourage them to, try to not consume alcohol or smoke while you take your ART. So, and
Great.
Be healthy.
Thank you so much, Dr. Excellent. So we're 2 minutes shy of 8 a.m. on the East Coast here. We're going to close out this session so folks can move over to some of the plenary sessions and other local partner sessions. Thank you, Dr. Excellent. Thank you, Dr. Cox, for joining us this morning and sharing your experiences, your knowledge, your expertise with the group. Thanks to the over 100 participants who joined. Thanks to my colleague Liz, who actually put together this excellent session. I just came in at the end, so it was mostly her who's to thank for this. Thanks to Avery and Alan for all of the support on the back end, and huge thanks to our interpreters, without whom the audience would be much smaller. So appreciation to all of you, and we'll see you in the plenaries and the other sessions. So thanks so much. Take care, all. It was a great session.